Hello, my name is Zeena-Britt Sanders and I'm going to be presenting the results of an fMRI neurofeedback trial that we carried out in chronic stroke patients. As most of you will be aware, motor impairments are very common after stroke. It's been estimated that about 75% of stroke patients suffer motor impairments immediately after stroke. And while some proportion of these patients recover functioning, approximately between 5 and 20%, there is still a significant proportion of patients who are left with ongoing, long-lasting motor impairments. And these motor impairments can have a very negative impact on patients' abilities to perform activities of daily living, impacting patients' independence and their mobility, and is also related to decreased health-related quality of life. Rehabilitation can improve motor outcomes, and especially it has been argued that greater intensity and duration of training is related to greater recovery. But this often requires one-to-one sessions with a physiotherapist, which can be very time-intensive and expensive. Also, traditional rehabilitation is typically focused on the stroke-affected limb, but research has started to explore the possibility of targeting the brain to see whether this can help improve motor functioning or boost rehab effects. After a stroke, we can see that there is altered brain activity. So when a healthy participant moves one of their limbs, we get a very lateralized brain activity pattern in the contralateral motor cortex. In comparison, when a stroke patient moves their stroke-affected limb, we observe a much more bilateral activity pattern, with increased activity in the ipsilateral motor cortex. This more bilateral activity pattern has been associated with worse outcomes in some patients, particularly those with milder impairments, but it's also thought to be compensatory in other patients, particularly those with worse motor impairments and more damage to the corticospinal tract. Therefore, depending on the patient, it may be beneficial to either try to decrease this ipsilateral activity, normalizing the brain activity, or to increase ipsilateral activity in order to help them compensate. And there have been several brain stimulation studies that have attempted to target this bilateral activity pattern in the hope of improving rehab outcomes. An alternative way in which you could target brain activity in a more endogenously driven way is through the use of real-time fMRI neurofeedback. During real-time fMRI neurofeedback, you have a participant inside the scanner, and you pre-process and analyze their data in real time and extract a feature of interest, for example, the percent signal change in a specific region of interest, which you then show back to the participant inside the scanner using a visual display. You then ask them to try and modulate the visual display, which corresponds to them modulating their brain activity. To date, there seems to be some promising evidence that people are able to use fMRI neurofeedback to modulate brain activity. In this recent systematic review that looked at previous fMRI neurofeedback studies, they found that of approximately 100 previous studies that they looked at, 2/3 of the studies showed that people were able to modulate their brain activity using neurofeedback, and another approximately quarter of the studies showed that there were at least some responders and some non-responders. So it seems that in general, people seem to be able to use neurofeedback to regulate brain activity. There's also been some evidence of promising behavioural results. So not all studies include behavioural measures, but of those that did, we can see that there have been some promising behavioural effects on a variety of different domains, ranging from cognitive functions to emotions and physiological responses. So if we can use neurofeedback to modulate brain activity, and if this can have a positive effect on behaviour, then this could be a potentially interesting therapeutic tool in disorders which are associated with abnormal brain activity. And people have tried to use fMRI neurofeedback in a variety of different clinical populations to varying success. But to date, there hasn't yet been any randomized trials in stroke patients. So here we wanted to carry out a randomized trial in chronic stroke patients, which was double-blind and sham-controlled. And we wanted to see whether the stroke patients could use the neurofeedback to increase lateralization of their brain activity. Our primary outcome measures were whether or not the patients could change the lateralization of their brain activity during neurofeedback, so measuring whether or not they could actually use the neurofeedback. And our second primary outcome measure was change in performance on the Jebsen Taylor Test, which is a motor assessment that I will describe later on. We also had a bunch of secondary outcome measures, which included whether or not there was any change on clinical measures of upper limb functioning. For this, we used the aberrant and the Fugl-Meyer, and also whether there was any change in the white matter tracts after neurofeedback training, seeing as there had recently been some work showing changes in the white matter after neurofeedback. So we recruited 24 chronic stroke patients who were more than 6 months post-stroke with mild to moderate motor impairments, and they were randomized into the real or the sham group based on time since stroke and their baseline score on the aberrant. So we ended up with 12 patients in each group, and here on the right you can see their baseline characteristics, and you can see that they're fairly well matched on these two factors that we randomized them on. So the patients were invited to attend 6 experimental sessions with us. So first they came in for a baseline session during which we did a baseline MRI where we acquired functional and structural data. And they also completed a bunch of motor assessments. Following this, they then came in for 3 neurofeedback training days, and on which they also completed the Jebsen Taylor Test on each day. And then they came back for 2 follow-up time points. So one week after the neurofeedback training, where we repeated all the same measures as they completed during the baseline session, and one month later where we just completed the motor assessments again. So I'm just going to describe in a little bit more detail what the neurofeedback intervention involved. So like I said, the patients came in for 3 neurofeedback sessions, and they were usually on a Monday, Tuesday, and a Thursday. And they always first completed a functional localizer, in which they were instructed to open and close both of their hands, and then the region of interest for the neurofeedback training was placed over the peak activity in the motor cortex. Then during the 3 runs of neurofeedback training, they saw 2 bars on the screen, with the red bar reflecting activity in the stroke affected hemisphere and the blue bar reflecting activity in the unaffected hemisphere. And during the neurofeedback blocks, they were instructed to make different movements with their stroke affected hand to try and increase the size of the red bar while keeping the blue bar as low as possible. So this corresponded to them increasing activity in the stroke affected hemisphere while keeping activity in the unaffected hemisphere as low as possible. Before and after the neurofeedback training, the participants also completed transfer runs where they just saw the instructions rest or move right or move left depending on which arm is stroke affected. And during the movement blocks, they were instructed to use whatever strategies or movements they had found effective during the previous neurofeedback blocks. So this was to test whether they could maintain any changes achieved with the neurofeedback when the feedback is removed. The sham group had exactly the same tasks and the same instructions, but rather than seeing the bars reflect their own brain activity, they just saw a video of a previous participant from the real group. So first of all, I'm going to be going through the results from our primary outcome measures. And so in order to assess whether they could use the neurofeedback to increase lateralization of their brain activity, we're going to be looking at the data from the neurofeedback runs themselves. In order to assess laterality of brain activity during neurofeedback training, we calculated a laterality index based on the activity in the regions of interest used for neurofeedback training. This resulted in values between -1 and 1, with -1 indicating activity lateralized towards the unaffected hemisphere and 1 indicating activity lateralized towards the affected hemisphere. So higher positive values would indicate that participants were able to use the neurofeedback to increase lateralization towards the stroke-affected hemisphere. So here I've plotted the results from the real and the sham group, and I've plotted the laterality index over the 3 runs of neurofeedback training on each of the 3 training days. Individual patient data is plotted here with the grey line, and as you can see, the individual patient data is very variable. So we first wanted to check whether or not there was any learning occurring within training days, and for this we took the average of all of the first, second, and third neurofeedback runs, and then we ran a linear mixed model with group and day as fixed factors and baseline laterality index as a covariate. And when we did this, we found that there was a significant interaction, and this appeared to be driven by patients in the real group increasing the laterality of their brain activity between the first and the third neurofeedback run, whilst the sham group did not change their laterality index over the runs. We then also checked whether or not there was any learning over neurofeedback training days, and so for this we took the average of the laterality index over all the runs within the training days, and then ran another linear mixed model, this time with group and day as our fixed factors and baseline laterality index as a covariate, and this time there was no significant main effects or interactions. So there is some indication that the real group appears to be able to use the neurofeedback to increase laterality across the runs within the training days. But as you can see, the performance is pretty variable and there isn't any evidence of a carryover effect across the neurofeedback days. So then we also checked whether or not patients can maintain neurofeedback learning, so whether they can continue to modulate brain activity without feedback. And for this, we looked at the data from the transfer runs, which were before and after the training, in which the patients did not see any feedback. They were just asked to use the strategies that they found effective in the previous neurofeedback runs. So for the transfer runs, we extracted the percent signal change from the regions of interest used for the neurofeedback training, and again calculated a laterality index, which I plotted here for the real group and the sham group, before and after the neurofeedback training on each of the 3 training days. And when we carried out a linear mixed model on the change in laterality index on each day and group, there were, unsurprisingly from when you look at these graphs, there was no significant main effects or interactions. So there wasn't any evidence of a transfer effect on a group level here, but as you can see, the performance was quite variable, and there was also quite a lot of variability in how well people could use the neurofeedback. So we also decided to have a look at whether this transfer variability is related to variability in how well people could use the neurofeedback. So we calculated the average transfer change as the average pre-post difference for each of the training days, regressing out the baseline laterality index. And we also calculated a neurofeedback success index, which was the average slope over runs within the training days. And when we correlated these two things together, we found a trending positive correlation for the real group, where patients who performed better on the neurofeedback, as assessed using the success index, also had a greater pre-post change in the laterality index during the transfer runs. And this was not the case in the sham group. However, this didn't quite reach significance. So our second primary outcome measure was change in performance on the Jebsen Taylor Test. The Jebsen Taylor Test is a timed assessment where patients are timed in how long it takes them to complete 6 different subtasks, ranging from things such as picking up small objects like paper clips and buttons, to picking up filled or empty cans. And what we were interested in is whether there was any decrease in the time taken to complete these tasks after training. So here I've plotted the time taken for the 2 groups across all of the subtasks of the Jebsen Taylor Test. And when we ran a linear mixed model on this data with group and day as fixed factors and baseline time as a covariate, we saw that there was a significant main effect of time, but there was no effect of group or group by time interaction. Therefore, patients were getting better over time and getting faster, irrespective of what group they were in. So in line with some previous studies, we also carried out an exploratory analysis where we divided these 6 subtasks up into tasks that measure more gross and more fine motor function. So when we did the same analysis, just looking at performance on the gross motor tasks, we saw that there was a significant main effect of group, with patients in the real group having faster performance on these tasks than patients in the sham group. In comparison, when we looked at performance on the fine motor tasks, there was no group difference between the real and the sham group, and the 2 groups performed quite similar to each other. So although our primary outcome measure was negative, there does seem to be some nice indication that there does seem to be a persistent improvement on gross motor function after this relatively short period of neurofeedback training. So next I'm going to be moving on to our secondary outcome measures. And these were all measures that were acquired during the baseline and at either one or both of the follow-up time points. So first off, for our clinical measures, we carried out the aberrant and the Fugl-Meyer. So in the aberrant, patients have to do a variety of different activities like pouring water into a cup or picking up marbles, and this is a measure of activity limitation. The Fugl-Meyer is more a measure of patients' motor impairments, so they are assessed on their ability to perform things like shoulder abduction or elbow extension. So here I plotted the patient's scores on the aberrant before the training and at the 2 follow-up time points. And although there was a main effect of time, so patients were getting better and scoring higher on this test over time, there was no group effect, so neurofeedback didn't seem to be boosting this improvement at all. And for the Fugl-Meyer, the data looks very similar, with patients getting better over time, but in this case the main effect of time didn't quite reach significance, and there was also no significant main effect of group. So unfortunately, we weren't able to show any effect on the clinical measures of upper limb function. Finally, we were also interested in looking at white matter changes post-neurofeedback. This is something we had looked at previously in a study with healthy participants who were asked to bidirectionally change ipsilateral brain activity, emulating the 2 different activity patterns that could be targeted in stroke patients that I discussed before. So participants had to make movements with their left hand and had to try to either decrease ipsilateral activity in a condition called the dissociation condition, or to increase ipsilateral activity in the association condition. And we found that healthy participants could indeed bidirectionally alter activity in the ipsilateral motor cortex, but interestingly, we also found changes in the white matter of the corpus callosum that were directionally related to the condition that the participants were in. So FA in this area in the corpus callosum was increasing in the association condition and decreasing in the dissociation condition. So this provides some evidence that neurofeedback could be used to induce structural brain changes. In the current study, we were interested in looking at changes in FA asymmetry of the corticospinal tract. This is a metric that has been associated with motor impairments in stroke patients. So FA asymmetry is a measure of the difference in FA between the two corticospinal tracts. And usually higher FA is associated with worse motor functioning. And this is something we could also replicate in the baseline data of our current study. And if you're interested in seeing some more data on relationships between brain structure and impairment, come check out poster MT752. So we compared this FA asymmetry measure before and after the neurofeedback training in our two groups. And here I've plotted the change in FA asymmetry with lower numbers indicating a reduction in FA asymmetry, so the two tracts becoming more symmetrical. And what you can see is that the real group is reducing asymmetry, whereas the sham group seems to be slightly increasing asymmetry. And when we did an ANCOVA on this with baseline as a covariate, we saw that the real group had significantly lower FA asymmetry compared to the sham group at the follow-up. So then we also wanted to have a look at whether this effect is driven more by changes in one of the corticospinal tracts over the other. So here I've also plotted change in FA in the two corticospinal tracts separately, with the affected hemisphere on the top and the unaffected on the bottom. And when we did a group by hemisphere ANCOVA, unfortunately it didn't quite come out in the statistics, but there was some indication that this was probably more likely driven by change in the affected corticospinal tract of the real group than by changes in the unaffected corticospinal tract or in the sham group. But like I said, unfortunately this wasn't significant. But what was interesting is that we also wanted to see whether neurofeedback success, so how well they performed in the neurofeedback, was related to these white matter changes. And whilst there was no correlation with change in FA asymmetry, there was a very strong correlation between change in the affected corticospinal tract FA and neurofeedback success. And this was not the case in the sham group, and it also survived multiple comparison correction across 6 possible comparisons. So the participants who were better at using the neurofeedback also had the greatest increase in FA in the affected corticospinal tract. So to summarize that all together, we found that the stroke patients were able to use the neurofeedback to increase laterality of their brain activity across runs within training days, but performance was quite variable and there wasn't any evidence of a carryover effect. Whilst we were unable to find an effect on our primary behavioural outcome measure, we did find some promising indications of effects on more gross motor function and on brain structure. For future work, including additional training of strategies that they found effective during the neurofeedback outside of the scanner may be a way to boost any behavioural effects. And also it would be useful to find ways to be able to identify and target people who are more likely to be able to use the neurofeedback. And additionally to harness the flexibility of neurofeedback in order to provide more personalised treatments. And with that, I'd like to thank you for your attention, as well as thanking all my lab members at the University of Oxford, as well as our collaborators at Maastricht University, and I'm happy to answer any questions.